I'm Dr. Deepak Talwar, Director Chair, Metro Center for Respiratory Diseases, Noida. I'm going to talk about management of chronic stable asthma. We know that the asthma burden is huge across the world and also in India. It is estimated about 5% of Indian population is suffering from asthma, which accounts for about 20 million people in India. So such a huge burden with a disease which is chronic and needs to be treated appropriately. And the next couple of minutes, I'm going to talk about how to manage asthma in our clinic practice day to day and get the good outcomes. We know that a lot of people suffered from asthma and they are leading normal lives. And they are all celebrities, they are politicians, they are presidents, and so on and so forth, so many people. But the bottom line is asthma is treatable. So how is it treatable? First, we need to reach the correct diagnosis, appropriate diagnosis of asthma. Since the symptoms of asthma are overlapped by symptoms of so many other respiratory diseases like cough, sputum and wheeze, that we need to differentiate it from COPD, we need to differentiate it from bronchiectasis, we need to distinguish it from so many other diseases which are mentioned here. How do we distinguish asthma diagnosis from all these other chronic respiratory diseases? The major factor remains which is the hallmark of asthma, is the variability. And variability is in both symptoms as well as airflow limitation. So whether it is cough, dyspnea, wheeze, they are all variable, they are not static, they are not progressive. Sometimes patients are absolutely all right, sometimes they suffer less, sometimes they suffer more. The response to the rescue medication is also dependent upon the underlying symptoms, and that will be also reflected in change in lung functions like FEV1 and variability in the peak expiratory flow rates. So asthma is a heterogeneous disease which is characterized by chronic airway inflammation. However, the symptomatology varies over a period of time, both in intensity as well as the magnitude. The variability, which is the key in the understanding of asthma, is not only in symptoms but also in lung functions, and that is what we classically try to look at, is the variability. So we want to demonstrate the FEV1 variability, PFR variability, and even post bronchodilator challenge tests which are being done in these situations. The goals for asthma management after an appropriate diagnosis is made is on two lines. One is the current control, which means that a patient who is presently suffering from symptoms must be relieved by getting the adequate medication. And these are basically looking at their symptoms, their activity levels, lung functions, and use of relievers. On the other hand, we are also looking at the future risk. These patients who are suffering from bronchial asthma are at future risk of instability and worsening, which are acute exacerbations, long-term loss in the lung functions, and of course adverse events due to medications being used for the management. So considering that the goals of asthma management are both current control as well as future risk, we need to define the management individually, case by case. So in the symptom control, what we need is that the patient should not have asthma attacks, they should have no recurrent symptoms, no dietary restrictions, no activity restrictions, as well as no loss of work and school, and of course no frequent nighttime awakenings. Patient should be able to peacefully sleep. So if you are able to get all this, then the patient is back to normal life and is as good as a non-asthmatic patient. In minimizing the future risk, the most important future risk is asthma exacerbation or permanent damage to the lung in the form of fixed airway obstruction. Since we are going to use long-term medications, there should be minimal side effects of them, and also we are bothered about long-term side effects of these drugs like corticosteroids. Pharmacotherapy of asthma, if you look at it, will depend upon the pathophysiology. We know the pathophysiology has two elements, inflammation and bronchoconstriction. So you need to look into both the elements, inflammation by using anti-inflammatory drugs and bronchoconstriction by giving bronchodilatory drugs. So the combination of inhaled corticosteroids, which is for controlling the inflammation, and bronchodilators, short acting or long acting, beta 2 agonist or anticholinergics, will form the mainstay of therapy for management of bronchial asthma. So to understand the asthma medications, we do realize now that those who are looking at decreasing the inflammations are called controllers, and those which relieve the symptoms by decreasing bronchoconstriction are called relievers. So these two medications are considered as the first line drugs, and then there are available which are called second line drugs or add-on drugs. So in the controller medication, which decreases the inflammation, inhaled corticosteroids is the mainstay, and the other drugs like long-acting beta-2 agonist, anti-leukotriene drugs, theophylline, anti-IgE, anti-IL-5 and oral steroids can also decrease the inflammation. So they are considered as add-on drugs because those patients who do not respond to first-line drugs will be using add-on drugs for them. For bronchodilator purposes, the first-line drugs are short-acting beta-2 agonists as well as inhaled corticosteroids and formoterol in combination. This seems a little out of question, but yes, even the anticholinergic drugs are bronchodilators and can be used in asthma as an add-on. Although the short-acting beta-2 agonist will be the first drug for the reliever of choice, but those patients who are inadequately responding to it will require add-on short-acting antimuscarinic agents, anticholinergic agents, or even in some patients we use combined inhaled corticosteroid and formoterol. We do understand that controller therapy for asthma is inhaled corticosteroids because it is a chronic airway inflammation, and since last 2 decades we know that inhaled corticosteroids are good for asthma and has to be used as a baseline therapy for almost all asthmatics in management of chronic stable asthma. The ICS is so strongly important that there are so many of them available. And if you look at the list of inhaled corticosteroids, there are plenty of them available, but most of the times in practice we are using budesonide and fluticasone. Budesonide is used if more than 800 micrograms per day, it is called high dose, 400 to 800 is called medium dose, and when we talk about fluticasone, it is more than 500 micrograms which is considered as high dose, 250 to 500 medium dose, and 100 to 250 as a low dose. Others like beclomethasone is an old drug. It's perhaps one of the first inhaled corticosteroid which was available, and the new one like which is cyclosanide are rarely used. Even mometasone is there available in the market, but these are more or less very less used in practice. So for practical purposes, we remember budesonide and fluticasone in their dosages which are low, medium and high depending upon the severity of asthma. On the other hand, long-acting beta-2 agonists are the drugs which are effective for more than 12 hours, and here we have salmeterol which is available in a dose of 25 micrograms and formoterol which is in the dose of 6 micrograms. So per day dose of salmeterol can go up to 100 micrograms per day and formoterol up to almost about 24 micrograms per day. But very importantly, the long-acting beta-2 agonists are never used alone for the management of asthma. They are used as an add-on therapy to inhaled corticosteroids because it has been shown that when ICS and LABA are combined, they have an additive or synergistic action whereby the anti-inflammatory action of inhaled corticosteroid is improved by using long-acting beta-2 agonists. Now, long-acting beta-2 agonists in such a situation will lead to decrease in the dose of ICS required to control asthma in such patients. So they are considered as steroid sparing in management of chronic stable asthma. It has been shown that if you add LABA to ICS, it not only improves symptoms, decreases exacerbations, improves lung function, but also leads to lower dosages of inhaled corticosteroids. Montelukast is an add-on drug which is leukotriene inhibitor, and it is used in the dose of adults 10 mg per day, and 6 to 14 years of age 5 mg, and less than 5 years we use 4 mg tablet or granules. It can be used at any age 6 months onwards, but it is effective in only 1/3 of people where the leukotriene pathways are very active in management of inflammation in severe asthma. So although there is no rationale of adding montelukast with antihistamines, but it is widely available and it is generally used in the initial part of the treatment when cough and allergic rhinitis are the important symptoms. Later on, antihistamines can be discontinued and patients should be continued on montelukast alone. Other add-on drugs like theophylline are available, which have got a weak bronchodilatory effect, and generally we use low dose theophylline in the dose of 150 to 300 mg per day. by which it actually modulates the cytokine production, and it has got what is non-bronchodilatory but anti-inflammatory effects, which are important in contributing to overall improvement in asthmatic patients. Now these days in asthma, we also have a role of tiotropium, which is long-acting but antimuscarinic drug, and it has been shown to be effective in the management of asthma where the patients are not adequately controlled with the first-line drugs of ICS and LABA. Oral steroids are most frequently used in the management of severe asthma or exacerbations of asthma in the short bursts, either from the OPD basis or from the hospital in the hospitalized patients. But this is only indicated in those patients who have been adequately treated with maximum dose of inhaled corticosteroids and long-acting beta-2 agonist and as an add-on therapy. But since there is a major issue about side effects of oral steroids, they are used in lower dosages for as short period as possible, and other factors which make asthma uncontrolled should be looked into more profoundly or more aggressively rather than using oral corticosteroids frequently in management of any patient of severe asthma. Now, as per the guidelines, the oral steroids have been pushed to the last possible resort in management of severe asthma because other targeted therapies like anti-IgE and anti-IL-5 drugs have been in the first choice if the patients fail on the conventional therapy for asthma. In the reliever medication, we classically know we have short-acting beta-2 agonist and short-acting antimuscarinic agents like ipratropium and salbutamol or levosalbutamol, but also you can use formoterol and inhaled corticosteroid when you use it in a SMART technology. Now, what is this SMART regimen? SMART regimen is that formoterol is one drug which can quickly relieve the symptoms, can actually dual itself as a reliever medication also. When it is combined with inhaled corticosteroids and patient is worsening, then the patient not only gets formoterol to relieve his symptoms, but also an additional dose of inhaled corticosteroids to look after the more inflammation which is happening in these patients. So this drug, if given in the form of patient who is already on these drugs, like formoterol and ICS combination, add on rather than using salbutamol, they use the same inhaler. Now, to understand this, if you remember that a patient who has been given ICS and formoterol, 1 to 2 puff morning and 1 to 2 puff in the evening, and in between, if they have symptoms, they can either use salbutamol 2 puffs or they can use 1 puff of same ICS and formoterol which is available to them. So what it does actually one inhaler does the purpose of controlling the disease from its symptom point of view as well as from the reliever. So what it means is that we have a reliever and a controller both by using a single inhaler in this situation. So rather than carrying two inhalers, one salbutamol, one ICS and LABA, we have one ICS and formoterol which is possible to be used in both the scenarios. But the important thing to remember here is it's only possible with formoterol, not with salmeterol. The reason being, formoterol has got quick onset of action, that is within 5 minutes. So the patient will get bronchodilatory effect and symptom improvement within 5 minutes, which happens also with salbutamol. However, with salmeterol, it is prolonged for 30 minutes to 1 hour. So it is not possible for them to perceive that their symptoms are relieved by using salmeterol immediately. Hence, patients who are on salmeterol and fluticasone or salmeterol and budesonide, they need to take along with them salbutamol as an SOS inhaler, while patients who are on formoterol or budesonide or formoterol or fluticasone can use same inhaler for SOS purposes also. This is also recommended in the guidelines where it is said that if the patient is in step 3, step 4, step 5 of asthma, they should be all given choice of either using salbutamol or formoterol and inhaled corticosteroids. So we not only prescribe medications in asthma, we also write the patient's prescriptions on the devices. And devices are as important as the medicines, because if the devices are not adequate, appropriate for an individual patient, the results of the asthma management will be far from what are expected, and of course will have a lot of uncontrolled asthma because the devices are not able to deliver the adequate medicines which you have chosen. So it is very prerogative for any physician who's treating asthma that they should not only decide on the right medication, right dosages, but also to give them in the right device form which the patient accepts and is able to use. These days we have the spacers available for a pressurized meter dose inhalers, and those patients who are using these inhalers can add on to these spacer devices, and these spacer devices will make them technically easy to use, decrease their oropharyngeal deposition, and of course there is less effect of sudden negative freezing temperatures of the gas at which it is released going at hitting the throat, which is called a cold freon effect, cannot be or rather be mitigated by use of this spacers. So spacers are also very effective when you are using high dose inhaled corticosteroids, because a lot of deposition which occurs in the mouth and the oral cavity happens into the spacer and leads to less side effects like oropharyngeal candidiasis by usage of spacers. So spacers are good for patients who are using pressurized meter dose inhaler who do not know how to use it accurately, because the spacers will give an opportunity to use it properly and also decrease the side effects which are caused by direct uses of pressure dose meter inhalers. The newer approach in the management guidelines for bronchial asthma is to assess the patient's diagnosis and give the treatment and then monitor the patient and reassess as far as the response and further management is concerned. So it's basically a cycle which starts with the assessment of the patient, adjustment of the treatment, and seeing the response and reviewing the response and reassessing the patient for readjusting the treatment. So this kind of a cycle will go on many times in the life of an asthmatic patient, and every time the patient comes, you need to look at it, which part of the cycle the patient is and how to progress from there further. Patients' management of asthma as per GINA 2019 is divided into step 1, step 2, step 3, step 4 and step 5. It is depending upon the severity of symptoms and other factors which are responsible for pushing the patients to develop exacerbations. It starts with step 1, which is a mild intermittent asthma, where these patients may not require inhaled corticosteroids and a SOS on salbutamol may be enough. In step 2, patients are given low dose inhaled corticosteroids, and there are alternative choices like anti-leukotriene drugs in them. In step 3, we either go with low dose ICS and add LABA to it, or we go to medium dose inhaled corticosteroids. In step 4, we go high dose inhaled corticosteroids or medium dose inhaled corticosteroids plus long acting beta 2 agonist, or high dose inhaled corticosteroids with long acting beta 2 agonist. And after step 4 is the management, which requires a very specific asthma specialist to look into what type of asthma it is that it is not responding to routine therapy. Now, if you look at the routine therapy in asthma is a use of inhaled corticosteroid and a long-acting beta-2 agonist plus minus 1 dose in the morning, 1 dose in the evening. If 80 to 90% of asthma, these drugs are taken appropriately in appropriate dosages, asthma will remain controlled. However, about 5% of patients will still remain uncontrolled despite adequate medication, adequate technique and adequate inhaler choice and adequate dosages of the inhaled corticosteroid and long-acting beta-2 agonist with one or the other add-on preventer therapy like theophylline, tiotropium or montelukast. So, when we think about the pharmacotherapy, step 1, as I told you, requires reliever therapy, that is short-acting beta-2 agonist, salbutamol on SOS basis. You can use controller low dose ICS in these patients if they are suffering or having future risk for exacerbations. In step 2, we have a reliever medication same as short acting beta 2 agonist. Controller has low ICS, and on add-on we can use again leukotriene modifier drugs or low dose theophylline. In step 3, we have reliever medication which is either short acting beta 2 agonist or formoterol and inhaled corticosteroid in combination, along with controller medications which can be low dose to medium dose or to high dose ICS in plus minus LABA combinations, and add on theophylline and leukotriene modifiers. In step 4, we have a further higher dosages of inhaled corticosteroids with LABA and add on same drugs. In step 5, if the patient is not yet controlled, previously we were all using oral corticosteroids, but now oral corticosteroids is down in the list, and what we have is what is anti-IgE and bronchial thermoplasty and sputum guided treatment like anti-IL-5s, which are dependent on the phenotype of the asthma, which is not responding to the therapies up to step 4, step 5 management of asthma. But pharmacotherapy is not the only treatment. Environmental control, education, written action plan, and very importantly to look and identify the triggers of asthma in every patient of asthma is also a must for management of asthma. So asthma control regularly needs to be assessed, asthma triggers need to be assessed, They need to be monitored on their spirometry or peak expiratory flow rate. We need to watch whether they are using the inhalers appropriately or not, look at their adherence, whether they are compliant or not, and all underlying comorbidities with allergic disorders like allergic rhinitis, allergic rhinosinusitis with asthma, the GERD, and things like obstructive sleep apnea need to be addressed. There are many potential triggers which need to be addressed when we are talking about asthma of the patients besides pharmacotherapy. So house dust mite, avoid pets, smoking, exposure to industrial pollution, domestic pollution, pollens, then molds and dampness on the walls, and of course sometimes it is even an occupation where chemicals are getting the person gets exposed to the chemicals, and they all are potential triggers. They need to be taken care of, and as far as possible environmental strict measures need to be deployed by the patient to take care of decreasing the asthma triggers in an individual patient. We have certain triggers which can start an asthma attack in an acute exacerbation, like beta-2 blocker drugs, beta blockers, non-steroidal anti-inflammatory drugs, ACE inhibitors, respiratory infections, exercise, weather changes, and of course the factors which are in the domestic environment like insect allergens, lot of stress psychologically, as well as pregnancy and mental trauma. Despite having asthma management being very simple, there are lots of people who do not know how to use their inhalers correctly, and almost 50% of patients who are using inhalers have never got it checked by their prescribing physician or by the asthma nurse. So what it means is, since these devices have to be used appropriately to get an adequate response, it is a duty of a physician who writes the inhaler that he must check that whether his patient is able to use the inhaler or not appropriately. So inhaler technique must be checked at every visit, every opportunity which an asthma patient brings to the consulting physician. Very importantly, we forget that the patients are suffering from many other comorbidities which are called asthma plus situations, and if you do not address them, the patients will continue to suffer, and we keep on increasing the dosages of the medications going from step 3 to step 4 and step 5 without realizing that they will not give any improvement in patient symptomatology, because underlying situation is a comorbidity which needs to be addressed, which can be rhinitis, sinusitis, GERD, obesity, hormonal influences, ABPA, bronchiectasis, respiratory infections, smoking and COPD, psychological disorders, and hyperventilation syndromes. And another important aspect of asthma management is asthma education. So every patient of asthma who's been given a pharmacotherapy, along with everything else which you are doing for the patient, he needs to be educated that it is a chronic airway inflammation and hence will require a chronic therapy. The key to success will be the patient adequately and appropriately able to use the therapy as well as take the environmental measures for that. So once the patient comes to the OPD, the flow chart is that try to recognize whether the patient is in acute exacerbation or not. If the patient is in acute exacerbation, the patient should be treated as a case of acute exacerbation of asthma. But if not, then we need to take a detailed history as to what is the asthma control, what are the risk factors for exacerbations, and measure his lung functions by spirometry, preferably if not at least by the PFR. And on the basis of these, we test the treatment issues, that what is the level of treatment required, whether it is step 1, 2, 3, 4. So level of control, risk factors, lung functions, and all these contribute to deciding which is the right appropriate level of management for an asthma patient. So this, after we have decided the step, if the patient is going into acute exacerbation, then acute exacerbation is as per the guidelines. Now once the patient is on the first time comes to us, then besides asking the symptom control for the last 4 weeks, that is 1 month, that is the most important questions which need to be checked are dependent on the asthma control test. So in the asthma control test, what we need to do is we need to ask them 4 questions. Do they have daytime symptoms more than twice a week? Do they have nighttime awakenings due to asthma? Do they have any need for using reliever drugs for more than twice a week? Or there is any activity limitation due to asthma? Depending upon how many yes comes to these 4 questions, patient is either well controlled if there is all no's. If there are 1 to 2 yes, it is partially controlled, and if this is 3 to 4 yes, patient is uncontrolled. And these 4 questions are related to last 4 weeks. So remember, whenever you see a diagnosed case of asthma who comes with symptoms to you, you need to ask for the asthma control. And for asthma control, we ask 4 questions in the last 4 weeks. So in last 4 weeks, daytime symptoms more than twice a week. Last 4 weeks, any night awakenings. Last 4 weeks, need for reliever drugs more than twice a week. And in last 4 weeks, activity limitation due to asthma. Level of control in asthma is a dismal. If you look at it, the survey, Asia Pacific studies, it does show that partly controlled asthma in 60% of patients, uncontrolled asthma in 40% of patients. So well controlled asthma as per GINA in Indian population is almost 0%. On the contrary, patients somehow feel very well controlled. Even 30% of patients on their own feel they are well controlled. So what it means is the asthmatic population in India is actually a very happy population which thinks that they are well controlled, but if they are put into the rigorous GINA control guidelines, we find them they are totally uncontrolled. So we underplay our symptoms and we accept them that they are perhaps acceptable and not symptoms which can be relieved even by the adequate usage of medications. This has to be kept in mind when we see asthmatic patients, because they'll have a lot of denial when they are asked about the symptoms. They will say they are perfectly all right, they don't need any treatment at all. But if you put them onto the test of asthma control, you'll find them they are not controlled at all. There are certain patients who are at high risk for asthma exacerbations and they need to be identified. Those patients who have got uncontrolled asthma, those patients who are excessively using SABA, they are people who are using like 1 canister in a month, 1 canister in 2 weeks. They are like patients who can get into acute attacks. FEV1 less than 60%. Inadequate use of ICS, either not given or patient not adherent or patient does not know appropriate technique to use it. Psychological or socio-economic problems, patients smoking or having allergen exposure ongoing, obesity, rhinosinusitis, food allergy, and patients who have got high eosinophil counts. Even pregnancy predisposes the patients to develop exacerbations. Previous history of admission into the intensive care unit, requirement of mechanical ventilation intubation, and multiple exacerbations requiring hospitalizations are all indications that the patient is actually at a high risk for exacerbations and hence carries a high mortality chances, needs to be aggressively managed. So once we start the initiation of the patient as per GINA 2019, we assess their symptoms. If we are using SABA less than twice a month, so patient says I use salbutamol only once in a month or twice in a month, then they don't need any controller medication unless and until they have an exacerbation risk potential. So all those patients who have a high risk for exacerbations, if any one of them is present, patient will require a controller medication in the form of low dose inhaled corticosteroids. On the other hand, if the patient has these symptoms which are like more than twice a month but still less than twice a week, they will require definitely low dose inhaled corticosteroids. And those patients who have got troublesome asthma symptoms, night awakenings and risk factors for exacerbations will receive medium dose to high dose inhaled corticosteroid plus minus long acting beta 2 agonist. If the patient is in acute exacerbation, then obviously short course of oral corticosteroid is given as per the treatment of acute exacerbations. However, physician's discretion is required when you start the treatment. Like we have this case who is 28 years male. Past 2 months he's been experiencing breathlessness while walking and climbing stairs. He experiences chest tightness, symptoms are relieved after the rest for a while, no nighttime awakenings, and he gets the bouts of sneezing which he as soon as he gets in the morning and goes for a bath. He's also got a blocked nose when he's at home. So in such a patient, if you take an environmental history, you'll find that he has recently shifted into the room. He's a known asthmatic since childhood and there is a lot of dampness in the walls, and his other roommate is a smoker. So in such patient, if we put the asthma control test, in the last 4 weeks, he had daytime symptoms requiring a beta 2 agonist. Yes. He is woken up in the night. No. Reliever medication use is not high. It is like twice a month. And of course, he has been not able to do the activities because there is a limitation in walking as well as climbing. So if we look at these things, you will see that the patient's asthma control is not very good. He is partly controlled. But he has a exacerbation risk factors like moldy walls and tobacco smoke. So in such a patient, you go to step 2 immediately and start low dose corticosteroids and an inhaled bronchodilator for the symptom control. Preferably, we either use a dry powder inhaler or a pressurized meter dose inhaler. So such a patient is given budesonide 200 microgram, 1 puff twice a day. He could also be given something like 50 micrograms of fluticasone twice a day with spacer. Salbutamol on SOS basis, you can give 1 to 4 or 1 to 5 puffs whenever he has cough, breathlessness and wheezes. He is advised to take avoid the exposures. Spacer is to be taken because that will help him to use the drug appropriately. And of course, the patient needs to be reviewed whether he is able to take the medications appropriately. He needs to be educated about why the drugs are being given and see the response. And if he is using the short-acting beta-2 agonist too frequently, he needs to see his doctor. And patients all, as I said, needs counseling about pharmacotherapy, comorbidities and identification of avoidance and triggers, which needs to be done even in this patient. And this patient had a very significant comorbidity, that is allergic sinusitis. So along with this treatment, patient must be given intranasal corticosteroids twice a day regularly to control his nasal symptoms, otherwise he'll continue to suffer. So don't forget the comorbidities. This is a second case, which is 53-year-old housewife. She is asthmatic on SOS bronchodilators. She has more breathlessness, wheeze, cough for last 3 months, was hospitalized for 3 days, and she is like severely limited in their day-to-day activities. She is not able to cook and clean the house. She has frequent nighttime symptoms. She is using salbutamol almost daily, 6 times a day. She is already taking derifalin 100 milligram thrice a day. She has profuse wheezes. Lung functions reveal FEV1 of 55%. The peak flow is 53% of predicted. Chest X-ray is normal. Room air saturation is 97%, which is normal. Now again, if we put it on the asthma control test, we find all yes, 4 yes. So patient is totally uncontrolled asthma. So if you look at them, which step you will be looking for in this patient, you will be left at step 4, where patient will require high dose ICS plus minus LABA, or medium dose ICS plus LABA, and add-on drugs available will be low leukotriene modifiers, low dose theophylline, which patient is already taking. So in this patient, what is lacking is the patient is using salbutamol, low dose theophylline, but requires a high dose ICS plus LABA or a medium dose ICS plus LABA. So patient can be given formoterol and budesonide in the dose of 400 microgram twice a day, or salmeterol and fluticasone 250 to 500 microgram twice a day. So after giving the pharmacotherapy to the patient, what is important is what more can be given. We need to definitely train the patient to use the inhaler device, look for any aggravating factors and address the comorbidities in an individual patient, give him peak expiratory flow rate for home monitoring, give a written asthma action plan that in case patient reversals, what more can be given, and the short course of oral corticosteroids should be available to them to start as soon as there is worsening noticed by them, before they could even reach the doctor. There is a shift in asthma management in last 50 years. We have traveled from theophylline to short-acting beta-2 agonists like salbutamol, to inhaled corticosteroids, to long-acting beta-2 agonists, to montelukast and combination of LABA and ICS. Ever since in 2000, the LABA-ICS combination was launched in India, it was thought that the asthma would be fully controlled in almost all patients. But some of the patients who do not respond to that, they would require add-on therapies. And now we have anti-leukotriene drugs like montelukast, we have long-acting anti-muscarinic drugs like tiotropium, and we also have now personally targeted therapies like anti-IgE omalizumab or anti-IL-5 like mepolizumab, available for management of the severest or perhaps the most sicker patients of asthma who do not respond to conventional therapies, which have come into the last step 4, which is given here, where bronchial thermoplasty, anti-IgE, anti-IL-5 therapies have been added, and such can be offered to the patients who do not respond to the rest of the therapy. After the patients have been given the therapy, they have to be followed up and monitored, and common issues at the to be addressed on the first follow-up is that the patient will come up with a lot of things that they think that they will get addicted to the nebulizers, inhalers, steroids, of course a lot of other people telling them not to use inhalers. So all this should be addressed on the first point, but what we need to do from our perspective is to check whether the patient can use the inhaler appropriately and adequately or not. Subsequently, these patients should be followed at 1 month by looking at whether their asthma is under control or not, check their lung functions if they have improved or not, check their inhaler technique whether they can use it or not. Asthma control test must be administered to see that how much control they have achieved since last 4 weeks of treatment, and then subsequently we need to consider step up or step down depending upon the asthma control. So you can take both the approach, step up and step down, where you use a lower therapy and find that inadequate response and increase and step up the treatment, or you can start with a high dose inhaled corticosteroids or a upper limit of that step therapy, and later on, once the quickly symptoms are controlled, patient goes down into the step down therapy. So stepping down or stepping up is generally considered not earlier than 4 weeks. Generally at 4 weeks we step up them. But before we step up and think that step up is required because patient is not adequately responding to the therapy which you have given, which is appropriate as per the GINA guidelines, step 3 or step 4 or step 2, whatever you have decided, you need to confirm the diagnosis, you need to confirm the adherence to therapy, you need to check that the technique of using inhaler is correct, no comorbidities are identified which can be addressed, and of course the exposure to environmental triggers must be addressed also. Stepping down, generally you need to maintain the patients for 3 months on the same dose with adequate control before you start reducing the dose of the medication. The first dose of the medication which is to be reduced is inhaled corticosteroids. Reduction is done in the approximately 25 to 30% at 3 monthly interval, and you come down to the minimum dose of inhaled corticosteroids at which the patients have got adequate control of symptoms without exacerbations, and maintain that dose for long period of times to have adequate control of asthma on yearly basis before you further go down on the therapy which the patient is using. So ultimately the key elements of asthma management are not only an appropriate pharmacotherapy but also its appropriate use and inhalational technique. Aggravating factors need to be addressed. Patients need to be addressed about the comorbidities and asthma education, and we also need to look into the compliance to therapy, and if everything is not working appropriately and the patient is still uncontrolled, patient needs to be referred to the asthma clinic for further management, where the high-end tests as well as phenotyping and perhaps many other things can be done in those clinics. So the final message for the stable asthma management is that the practice is focused around the patient, and patient has to be individualized. Each patient is different. We start with the controller therapy early, which is inhaled corticosteroids, and we ensure the adherence to this patient. The long-acting beta-2 agonists are basically as an add-on therapies to decrease the dose of inhaled corticosteroids and to have an adequate long-term maintenance in such patients with asthma. Good communication and developing partnership is the key to successful asthma practice, where we need to reminding them about the chronicity of the disease as well as the need for long-term management. Thank you.